this week on the BackTable podcast.
Like, we are talking now about a potential to cure patients, right? And, if we can offer intervention early on and cure patients with a defined course of therapy, despite the amazing results we have for combinations like EV, pembrolizumab in the metastatic setting, it's still going to be better to offer that. And so it really is critical now, perioperative immunotherapy and chemotherapy, be it cisplatin per the NAGA regimen or EV in the more recent EV303 data, is really a standard of care. And all patients should have the opportunity to discuss that.
My name is Alan Tan. I'm a medical oncologist at the Vanderbilt-Ingram Cancer Center. It's my pleasure to host this discussion on bladder cancer or urothelial cancer with my good friends and GU experts in bladder cancer, Brad McGregor and Amanda Nizam. Brad, you want to introduce yourself?
Yeah, excited to be here. I'm Brad McGregor. I'm at Dana-Farber in Boston, where we have less snow than Cleveland right now.
Amanda?
I am Amanda Nizam. I'm a GU medical oncologist at Cleveland Clinic, where we have much more snow and frigid temperatures than Boston, surprisingly.
Yeah, so I actually used to be in Chicago, so I'm no stranger to blizzards and snowstorms. But now I'm here in Nashville, where I'm actually craving some snow. We're going to go Friday to Park City for a nice ski trip for my wife's birthday. So that'll be nice. Anyways, such exciting time. I know we can talk for over an hour on urothelial cancer. A lot has changed in the last few years. But we're medical oncologists, and we usually see disease in a setting called MIBC, or muscle-invasive bladder cancer, or muscle-invasive urothelial cancer. Brad, why don't you start us off? How has this discussion changed in the past few years when you're talking to a patient? You refer to patient by urology. Patient has, say, T3 and 0 disease, muscle-invasive bladder cancer. They got tube RPT specimen. And what's the goal of the medical oncologist at this point?
I mean, I think it's changing at a rapid pace. And I think it used to be, we had data. I mean, go back at some initial data, SWOG trials from the 90s, early 2000s, where it showed that neoadjuvant dose-dense MVAC improved overall survival. We had meta-analysis, about a 5% improvement of 5-year-old survival with aggressive cisplatin neoadjuvant-based chemotherapy. Adjuvant cisplatin-based therapy didn't work, right? So in this situation where if a patient was eligible for cisplatin, they really should be getting neoadjuvant cisplatin-based therapy because it's hard to give cisplatin-based chemotherapy. But that's about half of the patients. Patients with bladder cancer are sick. They're older, comorbidities, poor renal function. And so it was tough, right? So a lot of the cases, patients were sort of being seen by surgeons and say, hey, this patient's not eligible for cisplatin. There's no need to see them. We'll manage them. And then we had the advent of immunotherapy and the adjuvant setting for the right patients. And then more recently, now we have perioperative immunotherapy with cisplatin using split dose, getting GFR down to 40. And then just in the past couple months, despite the government shutdown, we had rapid approval of EV with pembrolizumab in the perioperative setting. Patients with cisplatin ineligible and really sick patients, right? Patients in their 70s, T3 disease, T4 disease, no positive, showing not only improvement in DFS, but a marked improvement overall survival versus cystectomy alone. So I think the role of the medical oncologist is evolving rapidly. And while we often would see these patients in the select number in the pre-op setting, then all patients in the adjuvant setting, I think it's becoming increasingly clear that we need to be seeing patients with muscle-invasive bladder cancer as a multidisciplinary evaluation prior to their OR date. Because I think it's very clear that not only can we offer important therapeutic interventions by seeing patients earlier, but we also can get important prognostic information through ctDNA and appropriate testing to help guide therapy in the future. So I think it's a really exciting time to be treating patients with bladder cancer, because I think we now have an opportunity to intervene on nearly every patient with muscle-invasive bladder cancer to improve their chance of a cure and long-term disease-free survival.
Yeah, I totally agree, Brad. Amanda, like when you talk to a patient, they ask what stage the cancer is. What stage do you tell them?
in the muscle invasive setting?
Yeah, say T2 and 0.
Yeah, so T2 and 0, we explain it, show them a diagram of the bladder and the layers of the, superficial layers and the detrusor muscle layer, the perivesical fat. So I explain it that way. And then I also kind of, when I talk to them about perioperative therapy, I talk to them and kind of use the analogy of a weed killer, because we're not just treating only to shrink the tumor, we're also treating micrometastatic disease. We know that bladder cancer is a systemic disease. But when it is confined to the bladder, then we do, discuss that the goal is to cure, and that we use not only imaging as surveillance to assess our treatment outcomes, but also ctDNA as a prognostic marker, which we've seen from the early Niagara data, ctDNA that was presented earlier this year, and then also McGregor also showed us that those patients with ctDNA positive disease benefited from adjuvant therapy, whereas those who remained negative after cystectomy, almost all of the patients remained without disease recurrence even at 2 years. So that's how I discuss it. The ctDNA data we're still ironing out quite a bit, especially we're waiting that from the EV and Pembro perioperative trial to see if that data aligns with what we saw with the Niagara data. But even in the Niagara data, we did see that patients with negative ctDNA did still benefit from the perioperative approach, whether that was from the neoadjuvant component or the adjuvant component, that's to be determined. But these are the questions that are going to plague our field right now. And when we talk about precision medicine and bladder cancer, especially in the perioperative setting, the focus really, I think all of us could probably agree that people benefit from neoadjuvant systemic chemoimmunotherapy. But who really needs adjuvant therapy? We need to really refine how we give adjuvant therapy to patients, and that's what we're still finessing at this point.
To Amanda's point, I think it's really important. Like, we are talking now about a potential to cure patients, right? And if we can offer intervention early on and cure patients with a defined course of therapy, despite the amazing results we have for combination like EV, Pembro in the metastatic setting, it's still going to be better to offer that. And so it really is critical now, perioperative immunotherapy and chemotherapy, be it cisplatin per the Niagara regimen or EV in the more recent EV303 data, is really a standard of care. And all patients should have the opportunity to discuss that opportunity. So if you have a situation where you have muscle-invasive bladder cancer and you're looking to go to cystectomy, I think it really does, it's important to have these discussions and talk with medical oncologists, because I think intervening now, the magnitude of benefit with cisgem versus cisgem was higher than we saw with those like the ABC analysis, right? So, immunotherapy in the perioperative setting offers a huge advantage to these patients. And, if we extrapolate from melanoma, where it does seem like giving immunotherapy when there's disease in place offers a benefit, it's the same thing here. We're just adding chemotherapy to that to even better disease control. So I just think it's incredibly important that all patients with invasive CS.
Yeah, you guys both mention a lot, but let's just backtrack. Amanda, I asked you stage 2 bladder cancer to the patient. They think, stage 2 is not a big beast, is it? All right, this is pretty archaic. We can cure this easily. With stage 2 breast cancer, I heard the survival is good. With stage 2 colon cancer, survival is really good. But what's the survival traditionally with MIBC, which is labeled stage 2? Do we feel like this is undermining the actual severity of this systemic disease, as you mentioned?
By calling it stage 2?
Yeah.
No, I think, the way I approach my discussions with my patients, I don't like to use stage number when we're talking about bladder cancer, because it can be a bit confusing. I like to discuss it by non-muscle invasive, muscle invasive, and then either locally advanced, so like lymph node metastases only, or metastatic. I feel like that's a better, easier way for patients to understand. And then when we're talking about metastatic to the lymph node only, I feel like that's a very, very gray area where there's going to be a lot of art to the medicine, especially precision medicine, because some of these patients may be curable with systemic therapy and then consolidative surgery after that. But for stage 2, for muscle-invasive bladder cancer, again, we are treating a systemic disease. We're trying to treat the micrometastatic disease and obviously downstage the tumor as well. But when I talk to patients, basically, if they are going for radical cystectomy, then when we talk about prognosis, we've discussed pathologic stage, but now we're bringing in ctDNA status and kinetics and a longitudinal ctDNA results into that discussion.
So when you guys see patients referred from urology, are they already biased towards surgery? Or do you guys have a chance to discuss bladder preservation, like trimodality therapy, and maybe even other modalities? What's your discussion with patients?
So I will say we often see patients together. So patients comes in for referral, they've maybe seen someone else, and they'll come in, and a lot of patients are very educated and have ideas going in. And so I think that we certainly talk about all options, right? So for those small single tumors, less than 5 centimeters, no CIS, all those, we'd certainly think about it. But I will say where we probably think more about bladder preservation is we start with systemic therapy, and then those patients with exceptional responses, we're like, well, maybe instead of doing surgery, the patient's like, I have a really good response. Do I really need to have my bladder out? And I think that that's the unanswered question, right? So I think that as our therapies get so much better in the perioperative setting, like EVP has a path CR rate like over 50%, like unheard of. Like if we can potentially cure patients with systemic therapy alone, that's going to be amazing. So I think we're very early in this idea, but I think it's possible. And so I think right now, again, that chemo-rad situation, we tend to prioritize systemic therapy and then reassess in those exceptional responders. We're a little bit too chicken to just avoid any local control. And right now we're thinking we're doing like a chemo-rads approach as a consolidative approach.
Well, I mean, in Europe, there's a lot more bladder preservation done there, right? Even, before all the discussion on EV Pembro as a monster systemic therapy, the Europeans have been doing trimodality therapy probably like 50% of patients or maybe more. So why is there such a variance in the US versus Europe? I mean, the outcomes are no different, right? Like the 5-year survival, whether you have radical cystectomy after neoadjuvant chemotherapy versus trimodality therapy are roughly similar.
So, well, I think that comes down to the health system and financial reasons as well. Reimbursement. The US, as you mentioned, is much more surgically heavy. The uptake on bladder sparing therapy has been less than Europe, but I think it honestly depends on which centers you're at too. Some centers are more bladder friendly or bladder sparing friendly, whereas others are very high volume surgical centers, and those tend to be a little more biased in favor of radical cystectomy approaches. But I think, as Brad said, with these improving systemic therapies, there's going to be a lot more people that can spare their bladders. There are some ongoing trials right now, like, for example, Vadim Koshkin at UCSF has a trial of EV Pembro with chemoradiation for bladder-sparing therapy in muscle-invasive bladder cancer. And the question about consolidative radiation in those patients who do have exceptional responses is also going to come up as well. So, as Brad said, we are very early in that, but that question will come up, and I think it's very important that we discuss it with our patients. So if we go back to what you were asking me before, how do I discuss with my stage 2 bladder cancer patients or muscle-invasive bladder cancer patients? I ask about their preferences and what's important to them and their quality of life. What is your most important thing? Do you want your bladder out? Do you want to save your bladder? And that kind of guides the discussion in terms of what options we can work with. And of course, if someone has, T3, T4, and 1, we're not going to, I'm going to tell them about radiation, but I'm going to tell them I strongly, you are not a good candidate for this. The risk of recurrence would be much too high. But patients who are good candidates, very select patients, as Brad said, no CIS, small tumor, unifocal, urothelial histology, I do ask, and that kind of helps us guide the discussion. But the most important thing is that patients are informed of all of their options. And our radiation oncologists and our urologists, at least at Cleveland Clinic, are fantastic, and they all send. We actually have a bladder sparing clinical trial going on that was started by Omar Mian, the RAD-SG trial, that is looking at sacituzumab govitecan and muscle-invasive bladder cancer. So that's a small trial, about 20 patients, and we're almost done accruing for that. So we will learn about the role of ADCs and chemoradiation in the coming years, and it'll definitely be much more of a discussion with our patients as we get better control of the systemic disease.
To build on what Amanda said, I think one of the struggles I have when I have a patient who wants chemoradiation, I think it's always a real option, is, you started out by saying stage 2 is a systemic disease, right? And so I always had this concern that if I'm doing chemoradiation, is it really okay just to get like a chemosensitive dose of radiation, not that systemic chemotherapy, right? If this is muscle-invasive, I would give them chemotherapy for systemic disease control prior to cystectomy. And so I think as our systemic therapies are becoming so much better and available to so many more patients, I mean, even our radiation oncologists are like, well, maybe start with systemic therapy and then like, let's reassess after 9 to 12 weeks. Because I always had that nagging feeling in the back of my mind. By just doing like weekly cysts, how much systemic control am I really going to get? And I think that's not the way the trials were done. I realize that, but it's always something that we talk about.
No, I agree. Like 5-FU mitomycin or biweekly super low dose gemcitabine or weekly cisplatin. These are not great systemic agents on their own. They're radiosensitizers. So, but I do agree, like stage 2 bladder cancer in general might be a systemic disease, but maybe there's like a third of it that actually is not a systemic disease. And we'll get into this more later. I really think selecting with the right biomarkers like ctDNA. If there was a trial called Sunrise-2, which compared that pretzel device TAR-200 with citrilimab compared to bladder preservation with trimodality therapy, and it didn't meet this primary endpoint, but I think if they actually would have selected the patients that were ctDNA negative, I think perhaps if they did looked at this retrospectively, maybe it actually might have been at least a non-inferior trial. So, but speaking of more novel approaches, let's talk about, I think 3 of us were all at ESMO in Berlin this year, and super exciting consecutive years, right? EV302 in Madrid, and then now this. So Brad, why don't you take us through Keynote 905 or EV303?
Yeah, I mean, as we alluded to, right? So neoadjuvant cisplatin-based chemotherapy has been the standard of care. We had the addition of durvalumab, but even though that allowed GFR down to 40, a majority of patients still can't get cisplatin for hearing problems or heart issues. And so this is really an unmet need, how to offer that systemic control in the perioperative setting to patients that are ineligible for cisplatin. So this is an interesting trial. This is actually adapted over time. Initially, they said, well, let's just look at pembro in the perioperative setting versus surgery. And as EVP came out, it looked so good. They said, well, why don't we add EV, right? And so the design of the trial was looking at just the EV arm. So it's EV pembro, condition standard dosing for 9 weeks. So 3 cycles, followed by surgery, followed by 6 additional cycles of EV pembro. And then there's a total of 17 cycles of pembro in all, right? So for a total of a year versus going right to surgery. And so that was the design. I think as they went through, they allow patients who are cis refusing. That was a minority of patients. Starting out with, if you look at who is enrolled in the trial, we haven't seen the paper yet, but these were sick patients, right? Median age was in their mid-70s. A majority of these patients had T3 disease. Nearly like all but 20 or 30% had poor renal function. I mean, these were the patients we see in the clinic, right? These are the patients that come in, and what we saw is that there was an improvement, statistically significant improvement in both EFS and overall survival with addition of perioperative EV pembro versus surgery alone, with a pass CR rate, and depending on what you use as a denominator, patients who went to surgery or whatever, but it was well over 50%, which is unheard of. We haven't seen that with even dose stents and back in some of these trials. And so it really established a new standard of care. Now, at the same time, there's a ton of questions that we had now answered ourselves. Is like, do we really need to have pre and post-op therapy? A third of patients did not get adjuvant therapy. Why did they not get adjuvant therapy? What happened to those patients? What's that breakdown? I think those are going to be key questions as we look to the future. All we know is pass CR versus no pass CR. What were those no pass CR breakdowns? Were those some TA, T1, CAS? Like what actually was being seen there? What about ctDNA? We see a really nice analysis from McGregor. Are we going to see the same thing here? So a lot of unanswered questions, but at the same time, I think it really does tell us that we now have a highly effective systemic therapy offer in the perioperative setting to patients who are ineligible for cisplatin-based therapy. And the only way we're going to offer that patient is if we see those patients. And so I think it's just critical that medical oncology be involved with all patients with muscle-invasive bladder cancer early on in that treatment course. And then we look forward to the follow-up studies, right? So we have a similar trial versus cisplatin, which is completed accrual. We look forward to seeing those results. But I think it's exciting. And again, I think it's going to offer opportunity to cure more patients with a defined course of therapy.
And some of the upcoming trials, we're expecting readouts of more trials in the perioperative setting in muscle-invasive bladder cancer in 2026, including VOLGA and then the EV304, which is EV Pembro versus GemCis in the cisplatin-eligible population. So that may give us an indication in terms of optimal number of EV Pembro cycles in the perioperative setting. And then also VOLGA may help us answer a little bit about the contributions of the neoadjuvant and adjuvant phases, since that one does not have adjuvant EV in there, just the adjuvant immunotherapy component. But the real question is, and this was discussed at the Your Amigos Live meeting, and I thought it was a really great point, as we see more EV Pembro move into the perioperative setting, and I think most of us expect that EV Pembro in the cisplatin eligible population will also be positive. What is the role of cisplatin eligibility anymore in bladder cancer, whether it's in the muscle invasive or metastatic setting?
Yeah, good points you guys both bring up. Like, I look forward to VOLGA for two reasons. One, VOLGA looks at the contribution of EV plus durvalumab, right? Plus tremelimumab, so a CTLA-4 inhibitor. We really don't have CTLA-4 built into any regimens in urothelial cancer. So this will help us understand that. But also, yeah, do we need the adjuvant portion? Because we're not doing adjuvant EV in the VOLGA trial. Furthermore, as we talk more about ctDNA, VOLGA actually has incorporated ctDNA that's actually through a non-tumor informed approach. They use something called the GRAIL assay. And this one, they actually had like a 20 patient lead-in, safety lead-in, and they reported the ctDNA results on those patients. I thought that was quite striking. Non-tumor informed assay, the advantages of this is you get a rapid turnaround time. It's basically using a methylation signature that's very specific for bladder cancer, but also, yeah, turnaround time, we need to have that answer sometimes really, really quickly, about 7 to 10 days, whereas a tumor-informed approach usually takes about 3 to 4 weeks. And also you worry about not having enough tissue sometimes, especially when we talk about upper tract cancers where we don't really have a lot of tissue sent to us. But how about let's move on to ctDNA now. So IMvigor11, right? I actually had to take an earlier flight, but I actually saw this on video later and a lot of discussion about IMvigor11. But Amanda, why don't you start by telling us about IMvigor010, which started this whole story of ctDNA in GU cancers.
Okay, so the IMvigor010 trial was a phase 3 international randomized trial looking at adjuvant atezolizumab versus observation in patients with high-risk muscle-invasive bladder cancer, which used the traditional high-risk definition of YP T2 to T4 or lymph node positive after neoadjuvant chemotherapy, or P pathologic T3 to T4A or node positive without neoadjuvant chemotherapy. So that trial did not meet its primary endpoint of DFS, but when they looked at the ctDNA as an exploratory marker, they noticed that patients who did have ctDNA positive disease benefited from adjuvant atezolizumab. So that was used to develop the biomarker-driven IMvigor011. And the IMvigor011 trial is a phase 3 international randomized trial that looked at that same population of high-risk muscle-invasive bladder cancer. They could have either received or not received prior neoadjuvant chemotherapy. And so they looked at two arms here. Patients basically had, they were followed for up to 12 months post-cystectomy. So those that were ctDNA negative were monitored on surveillance with scans every 6 months for 2 years and survival every 6 months for 2 years. And ctDNA was monitored there. Once patients turned ctDNA positive, they were randomized 2-to-1 to either atezolizumab or placebo and then followed up. And that was the primary analysis population. And that is the trial that was presented at ESMO this year by Tom Powles and did confirm that giving atezolizumab in ctDNA positive patients did meet its primary endpoint of DFS and OS, which is the secondary endpoint. So what that trial told us was that patients who do have ctDNA positive disease after cystectomy are the ones who truly benefit from adjuvant systemic therapy. We also saw data that was presented by Tom Powell's at EAU 2024, which was the negative ctDNA surveillance arm. And that showed that most patients, over 90% of patients, even at 2 years, remain disease-free from recurrence. So this was the first trial to really validate basically using ctDNA positive disease to validate the benefit of adjuvant therapy. Now, where that plays into our current perioperative sandwich approach remains to be seen. So that'll be interesting as we see ctDNA data from more perioperative trials like Niagara and EV303.
Yeah, very nice. Yeah, this is a dwindling population, right, Brad? We also saw stuff from Checkmate 274, but how many people are going to actually get adjuvant therapy now? I guess you could argue those patients that went straight to radical cystectomy for whatever reason, or were node positive. But
I mean, I think as the therapy in the perioperative space has changed, this is like probably the most important trial that will not directly impact patient care for a lot of patients.
Exactly.
Just because we're not going to be having patients elderly. I mean, I think to me, it makes you really start thinking like, what do we mean by adjuvant therapy, right? So if you have a positive ctDNA, that's not really adjuvant. That's like early metastatic treatment, right? Because now you have evidence and metastatic disease. It's like a near guarantee that they're going to relapse if you look at
thank you.
raw.
I like that.
As opposed to like, what does adjuvant really mean? And so I think IMvigor011 is critical, right? It shows us that early intervention on a positive ctDNA test improves outcomes. And so that is what that says. I actually am not so sure I buy what to do with a negative, right? I think it shows that ctDNA is better as a serial marker, right? So if you look at the IMvigor010 or the Checkmate data, like patients who had a single negative, about 30 to 40% of patients still relapse, right? So like that single time point doesn't mean anything at the end of the day. It's helpful, but you can't feel great about things. And so the real question is, if you're negative up front, should you monitor and only give them IO when they relapse or convert? Or by giving them IO in a true adjuvant setting, could you prevent them from ever developing micrometastatic disease and improve outcomes even further? Because if you look at those curves, those patients who are negative do the best. And so if we can keep patients in that negative group, that's better. So to that point, I think Modern's incredibly important. So Modern's Open to the Alliance, and it's looking to say, in those patients, there's going to be a lot of patients allowed prior IO. But if you're in this situation, you're ctDNA positive, can you escalate therapy, add in a LAG-3? Does that improve outcomes with Nivo versus Nivo alone? And if you're negative, it's a non-inferiority. Should you give Nivo or should you do serial monitoring and do Nivo at time of conversion? The other point I want to make out is every 6 weeks ctDNA testing for a year. I mean, that's not an insignificant hurdle. And we talk a lot about scan anxiety with our patients. I mean, there is ctDNA anxiety. Like I have patients that get it and they're like very worried about what that ctDNA is going to be. And I think as we think about how this works in the clinic, I think the positive testing, super informative. I'm still not quite sure to do in that negative.
For those negatives, yeah, I agree. Every 6 weeks for negatives probably is a little bit of an overkill. And I usually do every 12-week monitoring for people who are negative that you think are probably already cured. And yeah, they're going to get these ctDNA tests either in the clinic or with mobile phlebotomy. And it actually relieves scan anxiety, right? Because if you're ctDNA negative, you're less likely to have something show up in the scan. But also, first of all of these data sets that we're talking about in IMvigor10 and IMvigor11 are using a first generation ctDNA assay using whole exome, looking at 16 variants. Well, when I think about increasing the sensitivity for detecting at landmark, right? Landmark is like 4 weeks or so after surgery. I think about maybe increasing time points. So every 3 months longitudinally. Some of these patients will convert later on. And I think we're going to be redefining adjuvant therapy later on by having patients treat upon molecular recurrence, just like they did with the Tombola study. And then we're going to get into whole genome testing soon, where you have more variants that we're tracking, whether it's thousands of variants, et cetera. We're going to get down to 1 part per million, maybe even better And so I think we're probably going to get that, 89% detection rate at 2 years, probably closer to 95% at that point. So, but you guys, does this solidify things for you guys? Were you guys using ctDNA before this data?
Yeah, so I was using ctDNA certainly in the adjuvant setting, but I think after I saw the data from Niagara and certainly the IMvigor011, I've actually started checking ctDNA at diagnosis and then tracking it because it does give prognostic information. So I've started every time even before I start therapy, I check ctDNA status, and then I check it I guess I'll check it every 6 weeks, at least going into cystectomy, and then depending on the result after, that will kind of determine the cadence post-cystectomy. But I do find it is a helpful augment to scans in terms of giving prognosis.
I do totally agree with Brad. Like, these patients that are MRD positive, they are destined to recur metastatically, right? So why are we giving them weak sauce with single agent IO, right? I think of the same thing with kidney cancer too. Like, if we ever get to a point where we're able to intensify patients in kidney cancer too, why are we giving them single agent pembro? Shouldn't we be intensifying these patients with a TKI or something like that? So I think that's the future of trials, and Matt Galski's trial is doing that. Who knows if LAG-3 is going to pan out in bladder cancer, but at least it's randomizing to an intensification, right?
Exactly. That's the approach that I think more contemporary trials are going to take, especially when we're talking about precision medicine in bladder cancer. I think that's really where the craft is going to be in the adjuvant setting in terms of de-escalation, escalation, switch therapy for those patients who still have ctDNA positive disease, pathologically non-PASC-CR disease. What do we do to those patients? Are you going to give them EV pembro if they didn't have a great response to begin with?
Yeah. Speaking of precision medicine and looking at other biomarkers, like ctDNA is a promising one, but there's other biomarkers. So do you guys up front, when you guys see a patient with bladder cancer, how you prioritize testing? Do you use your tissue for ctDNA first, or do you want to test it for comprehensive genomic profiling?
So it depends situation. So if I have a patient who has had a cystectomy and has T2 or worse disease and sending you out of chemotherapy, I'm getting NGS on that patient because I want to know if there's something that I can do. I'm going to get HER2 testing on that patient because now we have data for TDXD for her patient or HER2 positive, because that information is going to help me choose the therapy for the patient if I need it. And I think that's far more helpful in that situation than the CTA, which is great, but it can be more predictive, prognostic. I mean, I think that some of the information we get from the tumors can truly help us choose which of the therapies make the most sense. If you look at the perioperative management, it's sort of like the same for all, right? I think it's going to be EV pembro for all, likely is going to be the answer in 12 to maybe 6 to 18 months as we get this data. But we know that patients may relapse and everything. And so then to that point, what do we do after EV pembro, either in the perioperative setting or the metastatic setting? And that's where getting FGFR, HER2 IHC can be super helpful, especially as HER2 ADCs are, maybe going to move. We have data with them, maybe trying to move into the frontline setting. We had some nice data from China with DV and HER2 down to 1+. So I don't know. I think the role of HER2 ADCs with the new ADCs, the better linkers, better delivery payloads is evolving rapidly in bladder cancer as well.
Yeah, so you're definitely talking about metastatic disease, and I totally agree. You want those biomarkers in the metastatic setting, but in the we're still talking about perioperative setting. You're not prioritizing NGS for that setting, right?
It doesn't change my management in the perioperative setting today. Again, I get it in that perioperative setting because I'm worried they're going to relapse. I want to have the information in the future should they need it. But I don't think we had any data that we can sort of offer patients some this or that based on some change what treatment we're using based on that.
Yeah, so NGS in the perioperative setting, it can give you information on the disease or the biology driving the disease. So, and kind of give you a little bit of an estimate in terms of prognosis and what's driving. their cancer and their risk of recurrence. So we know like patients with MTAP deletions, that kind of thing, they're going to have more aggressive disease. But that's, if you have a surplus of tissue, like you have a TURBT sample, you have, a cystectomy sample. But really, when patients have either locally advanced or metastatic disease, you should be getting NGS and HER2 IHC up front on everyone.
Yes, for sure. One more thing before we wrap up the perioperative setting. So we talked about the accelerated approval. I mean, it was faster than EV Pembro in the metastatic setting. Like that was like right after Christmas. That was a Christmas gift for us. But we already have EV Pembro approved based on Keynote 905, which is pretty amazing. And, of course it was in the cisplatin ineligible population. But are you guys using it in cis eligible? Can you see a world where cis eligible would show you something dramatically different, the opposite? That's I know we're all academic oncologists here and we have to say the right thing, but really, if that was you, was this your family member? What are you giving them? I'm putting you guys on the spot.
So I think you're asking the question is cisplatin eligibility, what do we expect from EV304 essentially, from the cisplatin eligible population? I think we're going to see pretty similar pathologic CR rates. I don't think the cisplatin eligibility criteria is going to change the natural disease biology. So I think we're going to see comparable rates, if not better, in the cisplatin eligible population. And, I think we're going to see what happened with metastatic disease, where we're going to be much more liberal about what we call cisplatin ineligible.
Yeah, I would agree. I actually expect the data in the cis-eligible population to look markedly better, actually, than we saw in the trial. Only because you get 4 cycles in the pre-op map, there's 3 cycles. And if you just look at EV in the metastatic metastatic, and the patients with cisplatin eligible had a better outcome, right? So they're just fitter patient, better able to tolerability, all the therapy. So I do think it's super positive. And so to that point, yes, I think, I'm looking for reasons for patients to be cisplatin ineligible in the current era. I have patients that have been online coming in, right? So they're already asking like, well, what about EV Pembro? I saw this online, I saw this here, that. And so I think it's important to have that realistic discussion with the patient. Like, in the metastatic setting, EV Pembro beat platinum therapy. It beat cisplatin, it beat carboplatin. We'll see. We don't have firm data, but it's hard to believe it won't happen in the trials.
Brad's willing to at least say that much. But yeah, for me, cisplatin's dead. Let's just be honest. At least in the perioperative setting and in a frontline metastatic setting, for most people, or like 90% of people, right? I think it's pretty easy to make somebody cisplatin ineligible. The criteria is not too much of a fine line, creatinine clearance, et cetera. So
I will say the patients where I do worry about EV are those hepatic impairments. I think that's where I start worrying about, those mild hepatic impairments. That's where EV starts becoming a little bit concerned. It's not horrible, but it's one of those situations where those are the patients I think that EV, on renal function is not a big issue. I know we less than 30, but the hepatic impairment, I think if you look at some of the early data.
But would you dose reduce those guys in the curative setting? Would you dose reduce them?
I think these are unknown questions, but that's, to me, those are the patients, EVP for all. I don't know, the cirrhotic patients, those are the ones I worry about more.
Very, very, very narrow, population.
Yeah, very narrow population. But that's the one group of patients.
Yes.
I start, we talk about renal function all the time, it's cis eligible. I think the liver is probably the one area you want to think about.
Especially when you're combining with Pembro.
Yeah, and for me, I don't see too many cirrhotic patients, maybe mild hepatic dysfunction. I might dose reduce for those patients, but I maybe worry more about uncontrolled diabetics because we have seen people die of DKA, right? So those are the ones maybe are not going to be as eligible, I would say. And, we didn't even talk about variant histology. I don't think we should be giving EV Pembro for squamous, right? Would you guys agree?
Yeah, we know squamous is, platinum sensitive.
I think predominant variant histology for sure, right? I think is where you really...
Although anecdotally, I'm very bullish on plasmacytoid and EV Pembro. I've had some really unprecedented responses. I didn't do it. As a community oncologist, I thought it was very bold. Went to MD Anderson, got an opinion there. They're like, oh yeah, right on, EV Pembro. I was like, what? But he had a complete clinical response and refused radical cystectomy.
So
and had more of those as well. And Amanda, you probably have some data from Unite.
Yeah, so Tanya Jindal, one of our outstanding medical students at Case Western, previously was at UCSF, who's been working with us on Unite since its inception. She presented at ESMO this year a poster on EV-Pembro outcomes in patients with variant histology. So we actually did see some favorable responses in those with micropapillary variants, and then plasmacytoid is a little bit hit or miss. We didn't really see any with the neuroendocrine from my recollection, but neuroendocrine is a completely different beast. I think we all use chemotherapy in that. But squamous, she's presented previously on data with EV alone and EV Pembro and squamous, and we've had some comparable responses to what we would see with urothelial. And then also the Memorial Sloan Kettering team also presented this similar data on EV Pembro and variant histologies. So overall, it does seem to be active. There is a trial out of Emory that is looking at this EV Pembro in patients specifically with variant histologies. So we'll see what comes of that. But certainly in the interim, in the absence of randomized data, these large real-world registries will help us see how patients with these variant histologies do.
All right. Well, very quickly, we'll just touch a little bit on some precision medicine in metastatic setting, right? So we know EV-302. More than 2 years ago in Madrid, we saw standing ovation, doubling of overall survival, doubling of PFS, 68% overall response rates, just unprecedented stuff in our lifetime. So obviously this is transformative data. And are we curing people with metastatic bladder cancer?
Probably. I mean, you look at some of the initial data from the cis and alpha patients from like the cohort presented by Jonathan Rosenberg a couple years ago. I mean, 5-year survival, 5-year DFS over 40%. I mean, it's pretty small numbers, but it's pretty remarkable. So I do think we're definitely able to do far more now than we could before, but not enough, right? And so I think as we look at this, there's 2 questions. One, how can we make EV Pembro even better? And so I think there's efforts underway to do that. And then the second one is, what do we do if EV Pembro doesn't work, right? What do we do in that post EV Pembro setting? That's really a data-free zone right now, and that was a lot of opportunities.
Well, before we get to that, let's just talk about the other elephant in the room here. We're treating these patients until unacceptable toxicity. Baseline, our neuropathy is the limiting toxicity for most of these patients, right? I mean, there are some people that can go on like 20 cycles. It's like have minimal neuropathy. I just don't know who these types are, how we cherry pick them. But yeah, eventually by 6 to 8 months, people are starting to get grade 2 neuropathy. They can't button their shirts. How are you guys managing that? Are you guys de-escalating therapy somehow based on anything? Are you guys following ctDNA on those patients?
So I'm not using ctDNA in the metastatic setting to make treatment decisions. It does help to kind of see what the treatment is doing and how the disease is responding. But in terms of neuropathy, when I talk to my patients up front, I tell them you will eventually get neuropathy from this drug. It's a cumulative effect. Usually, median onset is about 3 months, but usually between 3 and 6 months is when we see the most. We do not want patients to get to grade 2 neuropathy because that really impairs quality of life. Patients can't button their shirts. Sometimes they can have some gait instability. We don't want patients to get there. So I tell patients up front, you will get this at some point. It is a cumulative toxicity with time. But if we're proactive about dose reductions, people can stay on treatment for much longer and still maintain their efficacy. We've seen that data from Dan Petrolak at ASCO 2024 that, those patients who did get full dose in the first 2 cycles and still had subsequent dose reductions still maintained their efficacy and response. We saw that from Shilpa Gupta's data at ASCO 2025, and the responders, patients who were responding were able to stay on therapy longer with, proactive dose reduction. So that's extremely important, especially because neuropathy is the most common dose-limiting toxicity. We also saw that in Unite in the paper we published in October. So if you're really proactive about this, people can derive benefit longer without getting to this quality of life limiting toxicity. And that's especially important as we're talking about sequencing of other agents that still use the vedotin payload, because we're seeing a lot of trials right now that are using vedotin payloads. And neuropathy is the most common with those payloads. So we have to be very careful in terms of thinking of sequencing and cumulative toxicities.
I mean, I think to that point, I think it's really important. These patients are here 2 days out of 2 weeks out of 3 weeks. And it's important just to always be asking about neuropathy, right? So I think the most effective strategy is hold and dose reduction. And if you wait to get to bad grade 2, you're not going to make going back, right? So I think, as Amanda said, educating those patients early on. And I have no problems, independent of scans or ctDNA or any of the above, if they're having toxicities. This is palliative therapy, even though we think we can cure patients, but we don't want to make them miserable at the expense of trying to make the next scan look a little bit better. So I think it is really important to dose reduce. I think to your point, Alan, can we use ctDNA to maybe de-escalate? Can it be an adjunct to scans? I think it's certainly very appealing, and it does make patients feel better when they're still abnormalities in the scan, but say we have to stop it for neuropathy because, you've had like 8 months and dose reductions, but your CTA is negative, and we'll just do pembro, and it does give that level of reassurance. So I do think as we look to the future, ctDNA clearance is probably going to be, we've seen that in the perioperative setting, the patients who clear ctDNA do better. It's probably going to be the same in the metastatic setting, right? There's data out there. And so can we start thinking about ctDNA clearance as a novel biomarker, a novel endpoint and thing to look at in some of these metastatic settings to help us de-escalate therapy?
Right. Yeah, I'm certainly a believer. Just, I'm doing this as a correlative at our center. And I think if people don't clear their ctDNA by 6 cycles, they're in trouble. And what do I see on their NGS reports when they haven't cleared ctDNA, or maybe their ctDNA started going up? Well, it's the usual suspects: FGFR mutation, ERBP2 alteration, MTAP, as Amanda mentioned. So yeah, I think, we need to do more work there as academic centers and look retrospectively and say, who are these resistant populations? Because pharma is definitely interested in combining. And Brad, you've done some studies with dual antibody drug conjugates, right? DADI-O. Tell me more about that.
Yeah, so when we did the DAD trial, so that's double antibody drug conjugate, EV-SG, post-platinum, post-IO, 23 patients. We actually showed that you can combine them at full dose together. And although toxicity at full dose, the best sort of bang for your buck was probably full dose EV with dose reduction SG to 8 mg per kg in the trials we did. But we saw a 70% objective response rate post-platinum, post-IO, and 5 of the 23 patients have durable CRs over 2 years now without disease. So pretty exciting. Small numbers, but that's the foundation for the DADI-O, so DAD-IO, EV-SG plus pembro. So this trial is open to Dana-Farber. We're open to other sites as well, looking to do EV-SG and pembro in the frontline metastatic setting. Have a high bar. EV pembro is great. So we're looking for an 80% response rate. But to your point, one of the things we're looking at is we're collecting blood to do ctDNA analysis and look at ctDNA clearance as one of these novel endpoints to sort of better assess the activity. So again, the idea of how do we make EV pembro better? That's one approach. Add more, right? And so we'll see how that plays out.
Yeah, as Amanda mentioned, the payload, DV data looks amazing in the metastatic setting and in the perioperative setting. I'm not sure about the CR rates that the Chinese data supported. That was kind of unusual, but it's unfortunate the payload is the same thing, MMA. So you're going to get overlap in that toxicity. But what about something like TDXT, right? That doesn't have the same payload. There's not going to be overlap with toxicity. So can you combine that antibody drug conjugate with EV pembro and maybe raise the bar there with response rate and survival? And tell us more about the HER2 story, because we're seeing in the DV story, even 1+ patients can have exceptional responses. Of course, it's enriched more in 2 and 3+, right? And the FDA approval right now is in 3+ for HER2. So what do you guys think?
Yeah. So the initial data that Matt Galsky presented from the phase 2 the RC48G001, I think that was at ESMO 2024. That I think most patients were HER2 low, 14 patients, and then HER2 positive, there were 6 patients. But the data looks pretty promising, and now we're waiting the phase 3, which is enrolling globally. And we'll see. And as you mentioned, the DV toripalimab trial in China, that was 1+, 2+, 3+, and that was obviously very, very impressive response rate. So the question now is, how do we treat will be, once we see the DV pembro data, will be how do we treat upfront locally advanced and metastatic patients who do have HER2 or, at least 1+ disease, depending on the results. How do we treat those patients when you have EV pembro and other things? We're also going to see there are other trials, the Forager, which is going to have the FGFR3 with EV pembro up front. So it'll be interesting to see how the upfront locally advanced and metastatic setting evolves over the next couple of years as well.
Yeah, I think one of the key questions is, are the HER2 positive, are they not EV responders? What's the overlap there? I think we don't know that data, but I think that there's a lot of unanswered questions. And I think as, we start learning more about the mechanism of resistance of EV pembro and more, I think there's going to be a lot more to be gained. But I think HER2 is here to stay in bladder cancer. Again, just like we have breast cancer, the HER2 ultra low, right? You get responses to T-DXd. I think as with the cleavable payloads, right? With the cleavable linkers, with those linkers that you don't have to have 100% does get into lysosome. I think that's key to some of these ADCs getting activity across a spectrum of positivities.
Yeah. So as you both know, HER2 and Nectin-4 are usually co-expressed quite frequently. So that is an important question. At ASCO GU, you will see some data from Unite on EV pembro outcomes in patients with HER2 positive disease. So we'll see that up probably in some real world data. And then from there, that'll be the question once we see the DV pembro data is what to do.
Yeah, it's just really amazing that HER2 we've been talking about for decades in gastric cancer, breast cancer. And for the longest time, we have not even known this to be a real thing in bladder cancer. And now we're talking 60 to 80% of people have this, which is, it's a gold rush. A lot of exciting molecules, bispecific T-cell engagers. But I think there's a lot of excitement in bladder cancer. We've talked about EV pembro really transforming this paradigm in the frontline setting, but 40% of people might be on that tail of the curve, but that also leaves 60% of people still going to die from their disease, right? So we need to make sure we're testing. If you don't check, you're not going to find it. And right now, HER2 and FGFR are the big guns that we need to be looking for. And, erdafitinib is rough, right? We can all agree erdafitinib is pretty rough, and it's not a very popular choice for our patients unless they actually have this mutation and they have nothing else clinical trial-wise. But as you mentioned, the Forager trial, this is a Loxo-Lilly trial, really good data on the safety and efficacy, even post-erdafitinib so far, right? What do you guys think about moving this into the front line with EV pembro? Is this then accrue well? They're doing a worldwide study called Forager 2. And I think as an academic oncologist, I would enroll patients in this study. Why? Because I know that these are the ones that are going to be refractory to chemo and to EV pembro, right? I have too many examples where these patients are refractory. So I'd rather get them on a well-tolerated FGFR inhibitor in that triplet setting. But I think many people many of our colleagues and community oncologists are like, why do we need to do better than EV pembro? EV pembro is so good, right? It's true, but there is a subset that's really tough.
Yes, there's a subset for sure. There are still, 10% of patients who do have primary progression, and we need to figure out who those patients are. And we're actually looking at that in Unite as well. But ideally, we would get that data from a prospective clinical trials. So the important thing is to identify those patients who are not going to respond to upfront EV pembro. And then those patients, I think, we can't forget about these patients with the less common subtype histologies like the micropapillary, the nested variants, the squamous cell. We really need to start doing more trials in those populations.
Yeah, really exciting times, guys. Thanks so much for the discussion tonight. Let's close up here. What are you guys excited about? What do you guys want to happen next in bladder urothelial cancer?
I'm really excited that I think EVP in the perioperative setting is going to cure patients and limit the need for therapy in the metastatic setting. And so I think all these questions had about what do you do post-EV pembro if they progress in the metastatic setting, long-term toxicities, with a defined course of EV pembro if we can cure more patients. I think that's going to be amazing. I think as we look forward to the future, I think, using ctDNA to help guide therapy, help make therapy decisions, and then novel approaches, combining with EV pembro or novel ADCs with platinum, like in the refractory setting. I think, after like 30 years of negative trials, it's like a positive platinum rate every year for bladder cancer. So I think we're in a very exciting time as we're really making leaps and bounds in how we treat our patients.
Yeah, I completely agree with Brad. I think, that space, that perioperative space, especially for patients with like locally advanced disease, where they're kind of in between metastatic and muscle-invasive, I think that's where there's going to be the most room for creativity and multidisciplinary collaboration with like consolidative studies, whether that's radiation or cystectomy. And that's probably the best part about treating bladder cancer is not only the rapid evolution and the dynamic field, but also getting to put our heads together with our urology colleagues and radiation onc colleagues to really be precise with our treatment and find the best treatment for each patient, because there is such heterogeneity.
Yeah. And I'll close with, I'm just really excited about ending radical cystectomy as we know it, right? I think we have the tools now. We have the molecular markers. We have ctDNA. We can get exceptional responses with systemic therapy. We even talked about non-muscle invasive disease, which I think will have a role in intravesical therapy to consolidate in the future. The pretzel devices, other immunotherapies intravesically, just explosion of riches. So with that, good night, everyone, and thank you for joining BackTable Urology, and we'll see you again.
Thank you for having us, and thank you to all the patients who have participated in trials and research. This field would not move forward without you.
Thanks. It's been a great discussing this data.
Thank you so much for joining us on BackTable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ONC. That's _BackTable ONC on Instagram, X, Blue Sky, YouTube, or LinkedIn.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe Legrazio,
Josh Spencer, and Jaden White.
Design and digital marketing led by Brian Schmitz.
social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
See you next time.